the opportunities for care or treatment at the end of life, that should be shared with the family, the surrogates that the patient wants that shared with, so that if the patient's at a point where they can't speak for themselves, the physician and the surrogates are on the same page about what it is the patient wants.
You say, do everything. They're really thinking that you're treating the disease.
The goal for the palliative care is to provide an extra layer of support for the patient to help alleviate suffering. Hello and welcome to Southern Remedy. I'm Dr. Rick DeShazo. My first inclination toward a TV program about end-of-life planning is to change the channel, and maybe yours is the same. I hope you won't do that. We have some interesting information for you. A recent documentary from Frontline and a study from the National Institutes of Health has suggested that doctors don't talk about end-of-life planning with their patients. And in fact, we find it hard to stop treatment when we should be doing that. We have assembled an expert group of Mississippi physicians, most of whom have had family experiences with this issue themselves, to help you understand the key points about end-of-life medical planning. Our first guest is Dr. Sharon Douglas. Dr. Douglas is a critical care specialist and professor of medicine who has served on national committees for the Veterans Administration and the AMA on end-of-life care. Dr. Mark Meeks is a geriatrician and director of the Division of Geriatrics at the University of Mississippi Medical Center. Dr. Vicki Pilkington is an internist and geriatrician and medical director of a hospice and a nursing home. Is it really true that doctors have trouble talking about end-of-life care? And if that's the case, why is that the fact?
Well, it is true, and a lot of physicians will tell you, it's an uncomfortable topic for me and my patients, and I don't think my patients are going to want to hear this, a lot of doctors say, and it's going to depress the patient, so I don't want to do it. Plus, doctors feel some discomfort because they say, I cannot be exact about the prognosis when I do have the conversation.
So in your geriatric practice, do you bring this up, or does a patient bring this up, or how does it usually develop?
In my experience is that it's usually brought up by myself. The patients don't typically bring that up with me, but it's a conversation I try to initiate once a patient develops a terminal or potentially life-threatening illness.
So with a nursing home patient and a patient in hospice, we'll be talking about what those particular levels of care are a little bit later on. Is this a component of moving into that level of care? Do you always bring this up?
I bring it up when their diagnosis or their illness leads me to bring it up.
So it's sort of a natural evolution.
Right, and with my relationship with my patient and how it develops and what stage they are, that's when I start to bring it up.
Now, I know that that's the traditional approach that we've been told, but I understand that in medical school now, you're teaching the residents to probably bring this up with patients earlier on than we've traditionally been doing that. Is that correct?
We are. We are actually teaching in medical schools, in residency programs, and in fellowship programs once your patients have been diagnosed, as Dr. Pilkington said, with an end-stage disease or an end organ disease, it's time to go ahead and have this conversation, even while the patient may still be feeling well, but because they're in a terminal condition or a near end-of-life condition, to have those conversations. And studies show that medical students who were graduating last year, graduating medical students, 50% said they agreed that they were ready to have these conversations, and another 35% of graduating medical students across this country said they strongly agreed that they were ready to have these conversations. So we are teaching this now.
Good. So why should our viewers be interested in this topic? What is the advantage to the everyday patient to begin to discuss this? Because it's not something that, we usually want to turn away from this topic, not turn to it. Why should we, even people who are relatively healthy, want to think about this?
Well, our medical system is set up to try to cure people of their illnesses, and everything's kind of directed to that goal. But for many people, there comes a time in the trajectory of their of their illness where unfortunately that's not feasible, cure is not feasible anymore. And so then there should be an appropriate shift to comfort care for them to make sure their end of life can be as high quality as is possible. And there's a tendency to just continue to keep pushing with treatments even when it's less and less likely they're going to benefit the patient. It may actually cause harm to the patient.
So what is an advanced health directive?
So an advanced health directive is an opportunity for a patient at any level, even in good health, to make choices about how they want their future decisions to be made. For example, someone young and healthy can say, I want my spouse to be my surrogate or my power of attorney for health care, and fill out advanced directives. More particularly, once a patient is near the end of life and has a terminal disease, the advanced directives may be something that the physician encourages with the patient, or the patient even brings up to the physician, so that their wishes can be carried out at a time they can't do that for themselves. But advanced directives can be filled out even in health, but more particularly once a patient has a terminal illness, those tend to be the times that most of us as patients and most of us as physicians focus on advanced directives.
So both of you are nursing home directors. Do you, and you provide medical care for large numbers of people in nursing homes, so do most of people in those institutions have advanced directives by the time you take over supervision of their care?
Yes, they do, because the social worker, doctors, everybody's involved upon their admission status. So we have to get that information when they're admitted to when they're admitted to the nursing home, to know what their wishes are.
In the ambulatory setting, the outpatient setting, where the two of you do most of your work, and in the critical care unit, are there differences in when that discussion should take place?
Well, you know, it's more obvious usually when the discussion needs to take place when someone's hospitalized with maybe an acute illness, or it's at the nursing home and they've been in a chronic decline. So it's kind of, you know, it's very natural to bring up the topic then. But certainly in the clinic setting, there are patients. I saw a patient this week that's got advanced lung disease from smoking and has a poor prognosis. And so it was appropriate to go ahead and bring that up to discuss what that patient's wishes are, because she could well show up in the emergency room next week acutely decompensated, and it'd be appropriate to know if she wants to be put on a ventilator or breathing machine, or if she wants to just be provided comfort care and be able to pass away naturally at that time.
So what is comfort care? What are we talking about? Is that different from regular care?
Yeah, so I guess the terms that people will hear and I think are sometimes confusing are palliative care and hospice. Everybody's heard of hospice, and many people may have heard of the term palliative care, and there's a lot of similarities and a few differences about those. I think if you look at palliative care, if you talk about the timing of when it's introduced, and you look at just what is provided and who's providing it, I think that'll kind of clarify the distinction between these two topics. Palliative care can be initiated any time someone is diagnosed with a potentially life-threatening illness. So that care can be started, let's use cancer as an example, when they have been diagnosed and sent to an oncologist or a radiation therapist to have treatment, then they can receive palliative care in addition to their routine medical care for their underlying cancer.
Is that comfort care? Is that what we're talking about?
And so that's not comfort care at this point. Let me just say that the goal for the palliative care is to provide an extra layer of support for the patient to help alleviate suffering. So it's a little distinct from what the oncologists would be primarily directing their focus on the cure of the cancer, whereas the hospice or palliative care physician, I should say, is going to be looking at some other factors such as suffering, different kinds of suffering. Some people.
So that's good. I'm beginning to understand what you're saying. That sort of fills in the gap that all of us have seen in care of patients, in that the specialist is very focused on all of the nuts and bolts of the specialty issues, but sometimes is so busy getting all of that implemented that there's a distance between the care that is being given and the care that the patient deserves, right?
Right, and so many people, there's so many myths out there that when they hear hospice, they just think, you just want to throw me out there to die. They don't realize we're still going to take care of you. It's just a different kind of care that we're here to help you transition to death, and that there is a such thing that you have an actual dignified death, that you don't suffer, and that there is support for your family members.
Okay,
and even
let's talk
afterwards.
about the moving from palliative care, which can come earlier or can be a part of hospice, right? So what is hospice? You supervise a hospice program. What are the goals of hospice?
Like Dr. Meeks talked about, when you can perform the palliative care of their symptoms of someone with a terminal illness or an advanced disease, then when we come in, we're actually going to provide palliative care to your loved one, but with the understanding that now you've reached a stage in your disease or you have a terminal illness that your life expectancy is usually less than 6 months. So we're going to shift our gears. We're still going to take care of you. We're going to take care of your whole family. We're going to take care of you, your emotional, your spiritual needs, your physical needs, and prepare you up until the time of your death. And then even when you die, we're still going to provide services and support for your family as long as they need it.
I have, in my own career and certainly in working with younger doctors, have noted a real hesitancy about even touching this topic. When they do touch it, they frequently touch it with the family first rather than with the patient, and trying to figure out who's going to bring this up. If you personally are in a setting where you want to talk about this and nobody's talking to you about it, either before you have a chronic illness or even sooner, how do you get this ball rolling? Do you go to the doctor? Have to talk to your family? How does this work? How is the best way to approach it from your experience?
Well, I think it's both. I think a patient with a terminal illness should talk to his or her physician about these things, but I think it's equally important that whatever the wishes, the goals of that patient based on that patient's values, that those goals are understood by the physician. And then once the physician has the conversation based on the goals of the patient about the opportunities for care or treatment at the end of life, that should be shared with the family, the surrogates that the patient wants that shared with, so that if the patient's at a point where they can't speak for themselves, the physician and the surrogates are on the same page about what it is the patient wants.
So the surrogate, you mentioned power of attorney for health care, and I think that is an entity that many people don't understand, seems to be very important in guiding this process. So when you get a power of attorney, and you can actually get them online, you can do them yourself. It's better to have a healthcare attorney if you can afford it, but so many of our people can't. What does that do? What does that bring into the, what is the positive thing about that for folks?
So the positive thing about it is it ensures that we as physicians and the family do the things the patient, we follow the wishes of the patient when they get toward the end of their life.
So give us some examples.
So an example would be pertinent for my patient population, since I do geriatrics. There may be someone with advanced dementia, and they no longer have what we call decision-making capacity, be able to understand or, their current condition and understand what their choices are. So in that setting, if the patient's unable to do it and they've designated someone as healthcare power of attorney, that individual might be a family member usually who can tell us what the patient has previously expressed is how they want to spend these last.
So this brings back memories in my own mind of that conversation you and I had in the middle of the night about my mother, who had advanced dementia, was in a nursing home, who had got pneumonia, who had basically been non-functional, and I had to talk to you about what I felt you ought to be doing for my mother so far as antibiotics, IV fluids, pain medicines, and so forth. And you had gotten me to get a power of attorney for health care from her. I talked to her about this. She was very verbal about it when she was younger and able to. I pretty much knew what she wanted, and I was able to tell you what I would think she would want at that point. How did that influence your care of her?
Well, I'd like to point out too, that's another advantage of the power of attorney for healthcare, is that it takes a lot of the stress off the family member who, because as Dr. Douglas I've heard say before, and I've followed her lead on this, is I say, this is not really your decision, but it's your idea of what your mother, you know your mother better than anybody else, and you know what she would want us to do in this situation better than anybody else does. And so it's really about what the my patient would want, and you're the person who best knows that from previous conversations y'all have had.
This may or may not be a mythology, a mythological thing, but at least among white medical professionals, there is this feeling that African Americans are less likely to want to talk about end-of-life care than Caucasians, and it's also related to other cultural issues and trust issues between doctors. And in our previous conversations, you and I have talked a little bit about the fact that many African American patients are more comfortable talking about some of these issues with African American providers than they are with white providers. And I understand that. Is that a big issue or a small issue?
I think it's a big issue, especially in our state and our population. I think we need to be reminded that we're still dealing with a generation who went through civil rights, who still went through segregation, who still can remember going to doctors' clinics that were segregated, being in a hospital that was segregated. There are still many Mississippians who believe our teaching hospital experimented on blacks and still experiment on blacks. I still hear that. There's still a belief that they get substandard care compared to whites. They still believe they get substandard medications when compared to whites. So when an individual stand before them talking about end-of-life care, they're already thinking, well, I'm probably here with this terminal disease, or I'm probably here because I got substandard care to begin with, or I got substandard medications. So now you want to talk to me about end-of-life issues and terminal life issues when I didn't get the appropriate or necessary medical care to begin with. So I think that's where the mistrust comes in among the African American community.
So what are the consequences then of not having an advance directive, a power of attorney, especially in the setting of that kind of dynamic? I would think that you would really want African Americans who have these kinds of concerns to do that, especially because it gives them, as I understand it, it gives them more control of who does what.
But I think because of the beliefs and the myths that are out there, I think a lot of times there's a lot of confusion among, you hear the terms, I want everything done, when we talk about code status and things like that. Well, to many African Americans, when you say do everything, they're really thinking that you're treating the disease and you're treating the illness. And a lot of times they don't know what's involved as far as putting someone on layman's terms a breathing machine or feeding tubes or anything that prolongs their lives. But I have many times, as when I was a hospitalist, for example, you have someone that come in, they're very ill, they're very sick. A CT scan shows that they have cancer throughout their body, and they didn't know that at the time. And then the nurse comes out and they say, I can't believe they want everything done. And then I go in there and I have to say, well, Mrs. Jones, do you know exactly what's going on with you while you're here? What made you in the hospital? And they usually don't. So then I have to sit there and explain what is going on. And then when I say, well, you know, this very well could lead to you maybe being put on a breathing machine or shocking your body or things like that. Is that something you would want? No, I would never want nothing like that. I want to just go home and maybe live whatever time I have with my family in peace. So there's a lot of miscommunication when it comes to African Americans.
So really, that the communication piece.
So Vicki, Dr. Pilkington makes an excellent point. You know, what often happens is patients come in and we as physicians don't do our job. And our first job is to make sure they understand their disease process, where they are and their current prognosis. Then we talk to them about what's important to them, what their personal values are, and what their goals are once they understand where they are in their disease process. Then we explain what these things are, like a feeding tube or a life support machine, which most people call the ventilator, the breathing machine, and what CPR or resuscitation is. And that's the key and the secret to doing it. So we need more physicians like Dr. Pilkington, and Dr. Meeks who do it just that right
Before
way.
they get to you in the critical care.
Well, and we actually have those conversations there, and of course in the critical care unit, most of the time we are having the conversation with the surrogate because often the patient's unresponsive. But if they aren't, we do talk to the patient. And like Dr. Meeks said, the approach to the surrogate to keep them from feeling that brunt of the burden is to say, what would the patient say to us if he could talk to us?
Okay, so we've talked a little bit about the value of an advance directive so far as communicating to health providers what people really want. And that's something that we all would like folks to know. And as I understand it, that can be changed at any time along the course. Then we've talked about an understanding of palliative care, which is an extra service you have to ask for or want so far as anybody with a chronic illness. And then an end-of-life decision is made, and that's when you move into hospice. Is that the normal transition?
Yes. So as Dr. Pilkin has already said, one of the criteria to be admitted to hospice is that the life expectancy is 6 months or less. And at this point, too, the expectation is that whatever treatment has been done before has unfortunately not been fully successful, and that chance of cure is not feasible any longer. So now the total focus is going to be on the quality of that person's life and what the end of their life is going to look like, however much time they do have left.
So a geriatrician is a geriatrician is a primary care doctor for older people. So you guys are constantly in the middle of serving the patient, doing the primary care, and advising the patient on all this information, instruction, and recommendation they're getting from specialists. Usually specialists are a bit more aggressive at end-of-the-life care than geriatricians. If you agree with that, how do you bridge that gap?
Yeah, I think, there's studies showing that physicians typically overestimate life expectancy by a factor of 5. So as a geriatrician in your practice is involved entirely with older adults who get chronic conditions like dementia that I mentioned earlier, or cancer, or heart failure problems, or end-stage lung disease. We have a lot of experiences seeing how that affects them and trying to give them realistic expectations of what might happen from here on. And the focus then becomes much more on their comfort.
So what do you have to talk to specialists and other physicians on behalf of the patient as a geriatrician?
If I'm asked to, sometimes I do. Actually, I had an elderly lady who several weeks ago had not seen a physician in over 10 years. And then when she sees me, of course, I do her preventive medicine, health maintenance, and she has breast cancer. So then she's scared, and the pathology shows that it is advanced and she needs to have a breast removed. And she goes talk to the surgeon I sent her to, and the surgeon and I have a conversation, and then she comes to my office hysterical because, again, she doesn't trust and she thinks that they just want to make money off of her. And so I have to call over there, and I have to call the oncologist, and I have to call the surgeon, and I have to say, hey, you guys need to talk to this lady. I'm sending her back over. So I will do that for my patients. I will pick up the phone, and I'll talk to them directly. Now, I don't know if this is practiced in all clinics by physicians, but I know that's something I do for my elderly patients because they do get confused about their prognosis.
We have some new legislation that has been passed that has a confusing name. Actually sounds funny. POLST. Sounds like some kind of farm implement or something like that. And so what is the scoop on that?
So the POLST was passed by the legislature in Mississippi in 2014, and it is going to be a written doctor's order after the doctor has discussion with the terminal patient about what their wishes about end-of-life care are that the patient can take with them. It's different from an advance directive. An advance directive can be filled out by a patient at any form of health or illness. This is an order written by the doctor after discussion for the patient who has a terminal illness, so that in the community, those orders by the doctor for that patient's wishes can be honored.
By other doctors?
By other doctor, by any healthcare provider, by an EMT, anywhere they are.
So what would you encourage family members to do?
I'd encourage family members, if their physician hasn't talked to them about it, they initiate the conversation with their physician to find out what the patient would want to do as they become more seriously ill or get toward the end of their life.
And what if the patient feels the doctor is uninterested or inept?
Well, I would certainly go to, seek out another physician, someone who's more comfortable just having these kind of discussions with the patient.
It's that important.
Yes.
Mm-hmm. And I agree. I like what Dr. Douglas talked about with advanced directives. It can be done at any age, and I really wish young people who get marriage counseling, I really wish that could even be included in marriage counseling, because I've seen young people and their spouse involved in a car accident, and now they have been left with some difficult decisions to be made, and if they would have had advanced directives, it would have taken the burden off of the spouse. So it's important for everybody at what stage or whatever stage or age in their life.
What kind of things are important to patients at the end of life?
Well, actually, studies show that patients want the simple things. They want to be with the loved ones that they love. They want to make sure sometimes that they get right with God. They may want to patch up an old relationship. They simply want to do the things that they enjoy, whether it's being at home with their pets, their little dogs, or being in their own bedroom. And so what patients wish when they realize what their prognosis is often changes. And as physicians, this is a powerful place to be with our patients in their lives, and we must honor their wishes, understand, like Dr. Pilkington and Dr. Meeks, the values that our patients have, and honor those, because the patients have a right to know that their time is limited, and then they need to fill that with what's important to them.
I want to thank our guests, Dr. Sharon Douglas, Dr. Mark Meeks, and Dr. Vicki Pilkington for helping us tonight. For more information about end-of-life care, visit Southern Remedy at mpbonline.org. For all of us here at Southern Remedy, good night.
Southern Remedy is underwritten by a grant from the University of Mississippi Medical Center.